Hello everyone. Today in this video we are going to discuss about approach to a case with bleeding disorders. As we know, bleeding disorder, that means it is an inherited disorder or maybe some problem after the birth, that means acquired disorders. So bleeding disorder is very much important and we divided bleeding disorder into two parts. One is acquired bleeding disorders and another is inherited bleeding disorders. So inherited bleeding disorders, amongst them the acquired bleeding disorder is most common, and inherited bleeding disorder is rarely found in children. Now before going to the disorders, we have to know how the hemostasis, that means how the blood is flow and how the blood is getting clotted after the vascular injury. As we know, the blood is going smoothly from in the blood vessels. So after the injury, the bleeding blood is going out. So how the blood is then clotted and how the blood is not going from the blood vessels, this is the process, it is called hemostasis. So let's discuss first the hemostasis. As you know, for the hemostatic process, the main component for the hemostatic process is the blood vessels. So if the blood vessels integrity is not there, that means the blood will not go smoothly to from heart to all the organs. So blood vessels integrity is most important for the homeostasis process. And next is the platelet. If the platelet is not there, then if there is an injury in the blood vessels, then the blood which is coming out from the blood vessels, first there is a platelet aggregation and platelet adhesion in that vessel's wall, as because the platelet is the first process, that means primary process of homeostasis. After that, the secondary process start. That means the clotting homeostasis is done by the coagulation factor. So there is a total 13 different factors are there for producing a blood clot. That means the secondary and the permanent clot. So primary clot, that means primary clot is done by platelet, and secondary clot, that means permanent clot, is done by coagulation factors. And anticoagulant protein is very much important to maintain the homeostasis, because this anticoagulant process, if it is not there, then there may be a chance of thrombosis, as because the blood which is after the blood vessels injury, when the platelet is getting activated and the coagulation factor is getting activated, then there is a plenty of RBCs and the fibrin is get deposited and it is covered whole the blood vessels. If the whole blood vessels get obstructed, so then no blood will go further from the blood vessels wall, and there will be ischemia or the organ. So the anticoagulant proteins is also, and the fibrinolytic process system is activated after the blood vessels injury. It is very much important because after the clotting of the stopping of the blood release from the blood vessels, the process is doing the rest of the clotting process to stop the clotting process. That means the make the patency of the blood vessels. So it is very much important to maintain the anticoagulant and fibrinolytic system for any homeostatic process. So if these two processes are not there, there may be a increased chance of thrombosis. It is very much important to get know. So if the platelet vessels was is leaky, or if there is a problem in the platelet or in the quantity or quality, and if there is a problem in the coagulation factor, that means quantity and quality of the coagulation factor is not there, if there is a deficiency of these three, there is a chance of increased chance of bleeding. So these are the three causes. If there is a deficiency or problem in this, there is a chance of increased chance of bleeding. And if these two proteins and these systems are not activated, then there will be a chance of thrombosis. Now come to the homeostasis part. So first, when there is an injury to the blood vessels, when the blood vessels wall getting injured, there is a vasoconstriction, as because the after the injury there is a sympathetic nerve activity, and the sympathetic nerve causing constriction of the blood vessels, and this intimal layer is made up of endothelium, and below this intimal layer there is a tissue factor is present, and also there is a von Willebrand factor is also there. So this there after the injury, these two factors are getting released. That means tissue factor is also released, and there is a release of von Willebrand factor. So this von Willebrand factor getting attached with the platelet present in the blood vessels. So this von Willebrand factor is attached with the platelet, and this platelet getting activated, and this von Willebrand factor attached with the platelet by GP1B. That means GP1B is getting activated to is present to in the platelet wall, that causing attachment of the platelet with the von Willebrand factor. So after getting the platelet activation, there is a activation of the platelet peptidoglycan proteins, and there is a increased release of ADP, and this activated platelet get attached to the vessels wall, and after this activated platelet also activate the another platelet in the blood vessels wall, and there is a platelet aggregation. That's so there is a activation and there is a aggregation of the platelet. This is the primary clot formation. So this is the primary homeostasis. It is done by the platelet. So if there is a deficiency of the platelet, so there is increased chance of bleeding after the injury. After that, the primary clot is formation. After the primary clot is formed, there is a secondary homeostasis. It is done by this tissue factor. After activation of the tissue factor, this tissue factor getting activate the clotting factors. What are the clotting factor? After the tissue factor getting activated, it activates the factor 7, and this factor 7 is getting activated, which activate the factor 10, and it is this factor 10 is also activated by the other intrinsic factor. So this is the extrinsic factor, and this is the intrinsic pathway. Intrinsic pathway start with the factor 12, and this factor 12 is getting activated by the by the platelet and also by the other factors, which is getting activated after the primary clot formation. So this is the intrinsic pathway. Intrinsic pathway having what are the factors is present in intrinsic factor? That is factor 12, factor 11, factor 9, and lastly the factor 8. So these are the 4 factors which is very much important for the intrinsic factor activation. The first is the extrinsic factor activation. After that, there is the intrinsic factor activation by all the thrombin itself and also other factor of the platelet. So the intrinsic pathway, it is activated by factor, tissue factor, and the peptidoglycan. It is the factors are factor 7, and the common pathway, it is very much important. The common pathway is factor 10, then factor 2, that is prothrombin and fibrinogen, and also the factor 13. So these are the common pathway. So intrinsic pathway is by factor 12, 11, 9, and 8, and extrinsic factor is factor 7, and the common pathway are factor 10, factor 5, factor 2, factor 13, and thrombin factors. And also calcium, it is very much important. It is in some MCQ. So these are the pathway in which there is a clot formation, and clot formation is by the maturation of the fibrinogen to fibrin. This is the main pathway. This fibrin is getting, then the fibrin, there is a clot formation. Fibrin in getting activated, and after the fibrin thrombin getting activated, this thrombin convert the fibrinogen to fibrin, and the coagulation factor produce a permanent clot of fibrin along with platelet and RBCs. So there is a formation of a clot. After this clot formation, there is secondary hemostasis. There is a this process. If the process is getting continued, then there is a complete blockage of this blood vessels also. After the plate clot formation, there is activation also before and simultaneously there is activation of the antithrombolytic system and also the fibrinolytic system by the plasminogen. So these are the fibrinolytic system is getting activated. This plasminogen getting activated, and this plasminogen is converted to plasmin, and which is getting fibrinolysis all the rest excess amount of fibrinogen, and there is a healing. So this is the process in which blood vessel homeostasis is there in the after the injury. So after the vascular vessels injury, there is a exposure of the von Willebrand factor. This is very much important. So exposure of the von Willebrand factor in the subendothelial matrix, which getting activated the platelet. So after the platelet activation, the platelet getting release of ADP and other tissue thromboplastin factors and collagen, which causing the aggregation of the platelet. So platelet is very much important for the primary clot formation, and after the clot formation and after the primary clot, there is the vascular injury. After the vascular injury, there is a simultaneous release of the tissue factor, which getting activate the factor 7 that means the extensive pathway, and this extensive pathway converts the factor 10 and thrombin to fibrinogen, and this thrombin also activate the intensive pathway. So thrombin is one of the factor which activate the intensive pathway. It is an important MCQ. So after that there is a conversion of the fibrinogen to fibrin, and this fibrin produces hemostatic plaque. And antithrombin factor, what are the antithrombin factor is present in the body? There is antithrombin 3. It is very much important because it deactivates the thrombin conversion of thrombin. That means this antithrombin 3 inhibit the formation of thrombin, and also protein C and protein S, which is produced by the liver, which is deactivate the factor 5. That means protein C and protein S is deactivate the factor 5. So these are the very much important MCQs. So by this chart we can go the clinical features of all the different types of bleeding disorder. So if there is a problem in the willebrand factor, as we know willebrand factor activate the platelet, and also it is a good carrier for the factor 8. So if there is a willebrand factor deficiency, there is a platelet is not getting activated, so there is a release of after the vascular injury, there is a decreased amount of platelet getting activated, and that's why there is a decreased amount of primary clot formation. And also this factor 8 is a good carrier of the factor 8, so there is a deficiency of factor 8 also. So that's why there is a problem in both the primary and secondary homeostasis. So this causing, first is the purpura patechi, and also there is a chance of bleeding, that means deep bleeding, that means hematoma or hematose. So von Willebrand factor deficiency may present with purpura patechi or excess amount of bleeding from after the menorrhagia in children, in girls, and also there may be a chance of hematose because of deficiency of factor 8. So now the clinical features. Before going to the clinical features, we have to know the plate problem. If the problem is in the platelet, so there is if the problem in the platelet, that means the primary clot formation. So as we know, the blood which is going from the vessels walls, there is a recurrent trauma in the vessels walls every time, because when we are walking, or when we are doing work or anything, there is a minor injury every time happens in the vessels walls. So if the primary clot is not formed properly, so there may be a leakage of the RBCs every times, and there is this causing small purpura patechi. But as the platelet count is decreased, but the coagulation factor is there, that means no excess amount of blood is released from the body. So that means there is no release of excess amount of blood. That means there is no presence of any large amount of hematose or deep bleeding or problems. So coagulation platelet factor deficiency presents with a purpura, firstly present with the purpura patechi or ecchymosis. After that, if there is severe deficiency, there may be a presence of bleeding, excessive bleeding, but it is rarely in platelet problems. But in case of coagulation factor deficiency, as there is a coagulation factor deficiency, the primary clot is formed after injury, but if the injury is severe, then there is the secondary, that means the permanent plaque is if not formed, that means there is a continuous leakage of the blood. So that's causing bruise, or that may cause of severe bleeding, that means underlying muscular bleeding, huge amount of underlying muscular bleeding like hematose, or there is a deep seated hemorrhage. That means clotting factor deficiency having huge amount of bleeding more than the platelet deficiency. It is very much important to know. Now the causes of bleeding disorders. First is the platelet problem. As we said, problem is the most important. Firstly, it is the vascular problems. If there is a problem in the vessels wall, because the vessels wall, if it is not smooth, then blood is not going smoothly to the organs from the heart. That means that if the vessels wall is leaky, or there is an injury in the vessels wall, there is a continuously bleeding, manifestation of bleeding. So vascular problems, that means if in SLE there may be leakage of the vascular, or there may be a prolonged steroid therapy. If the patient taking prolonged steroid therapy, the vessels wall are leaky, and also there is a fragile of the vessels wall, that causing presentation of the purpura or patechi. That's in scurvy. There is a vitamin C deficiency, and this present with some problem in the vessels wall, and the vessels was getting leaky because there is a decreased amount of thromboplastin in the as there is a decreased amount of fibrinogen, and there is a decreased amount of fibrinogen causing decreased amount of fibrin clot. Ehlers-Danlos syndrome, that means there is a elasticity, increased elasticity in the body, and also there is a vascular leakage, as because the vessel wall which is having some collagen fiber, the collagen fiber is decreased, so there is a leakage of the vessels also. So the patient may present with purpura patchy spots, and other is also there is a signs of easy breakage of the bones, as because the collagen is deficiency or collagen is decreased, amount of collagen is there, and also the patient may present with elasticity, increased amount of elasticity in the joints, and the hereditary hemorrhagic telangiectasia, in which there is also deficiency of collagen. So this vascular problem may present with a purpura spot or patchy in the body, and there is a problem in the bleeding. Now the platelet disorder, either there is a deficiency of the platelet, that means qualitative decrease amount of, or there is a quantitative problem, that means the aggregation problem. So if the platelet amount is decreased, that is either the platelet decreased amount of platelet is due to the decreased amount of production of the platelet, or there is an increased amount of consumption of the platelet, or there may be a the platelet is produced from the bone marrow sufficiently, but it is when it is in the circulation, there is an antigen against the platelet which destroy the platelet, causing decreased amount of platelet. These are the three things where there is a quantitative defect of platelet disorders. That means this ITP. In ITP, there is an antigen formation, and the platelet which is small, the bone marrow is producing normal amount of platelets, but the platelet which is present in the circulation, it is there is a antigen antibody reaction, and this antigen antibody reaction cause killing the platelet and decreasing amount of platelets present. NAIT means neonatal alloimmune thrombocytopenia. In this means the mother having some antibody against the infant's platelet or against the mother's platelet, and there is a decreased amount of platelet because there is a consumption of platelet as the antigen antibody reaction. So this may be a problem of platelet amount of platelet. There may be a TTP, that means thrombocytopenic purpura or HAS. This is this is congenital disorder, and this is acquired disorder of the same problem, same symptoms, same disease spectrum. So there is a decreased amount of Adams 3 protein, and there is a decrease, there is a toxin produced by the Shigella or some E. coli, which is in which there is a decreased amount of platelet, as because there is a antigen antibody reaction of the platelet, and also there is a microcytic MAHA, that means microcytic hemolytic anemia is present, that means cystocytes is present, that this HUS may be present with AKI along with thrombocytopenia, that means purpuric spot all over the bodies, and there is a decreased amount of urine output, and there is a anemia. DIC means DIC is very much important, and in DIC there is a decreased amount of platelet, as because the body having huge amount of sepsis or any other metabolic problems, in which there is a decreased amount of production of, also the production of the platelet is decreased, and also the consumption of the platelet is increased, as because there is a huge amount of bleeding is going on. The infection, most common infection which causing decreased amount of platelet problem, just like dengue, and also there is a viral problems, viral infections like RSV virus or PCV, RSV virus or PCV virus, or some HCV virus or congenital torch infection, that may be a causes of decreased amount of platelet. Aplastic anemia, there is a decreased amount of formation of all the 3 cell layers in the bone marrow, and there is a increased chance of purpuric spot all over the body. TAR syndrome, that means there is a increased amount of consumption of the platelet, as TAR means thrombocytopenia absent radius. The child is having absent radius bilaterally, and also there is a thrombocytopenia, and there is the thrombocytopenia is due to the consumption of the more amount of platelet in the body. And Kasabak-Meit syndrome, in which there is a huge amount of hemangioma present in any part of the body, in which there is a platelet getting deposited on that part of the hemangic spot, and which causing decreased amount of platelet all over the bodies, and there is a increased chance of bleeding, and also there is a presence of purpura. Hypersplenism or malignancy, in which there is a increased amount of consumption of the platelet. And the qualitative defect, there is a Glanzmann thrombosthenia and Barnard-Soley. In Glanzmann thrombosthenia, what happens? There is a problem in the platelet adhesion. That means platelet cannot adhere with the volume factor and also the endothelium, as because there is a deficiency or decreased amount of GP1B. And in Barlasoli, there is a problem in the platelet aggregation. That means after the addition, the platelet cannot activate other platelet, and there is a decreased amount of platelet aggregation. As because the aggregation is platelet is aggregated, that means one platelet is attached with another platelet by the GP2B3A protein. So there is a problem in the deficiency of the GP2B3A protein. So this is Barnard-Soley and Gleason thrombocythemia, in which we patient may present with a purplic spot or some purplic spot or pathology. Now the coagulation factor defect. The most common coagulation factor defect is the von Willebrand disease. It is an autosomal dominant disorder in which there is a problem absence of von Willebrand factor. That means qualitative defect or quantitative defect of von Willebrand factors. Von Willebrand factor is very much important as it is present below the endothelium of the blood vessels, and this von Willebrand factor doing two work. First is it is activate the platelet, and also it is the carrier of the factor 8, which is very much important for the permanent homeostasis. So in von Willebrand factor, it is autosomal dominant. There is a three types of von Willebrand factor disorder. It is von Willebrand 1, type 1, type 2 and type 3. Type 2 is divided into plenty of other types, that means type A, 2A, 2B and type N, but it is not very important. In type 1, that is a decreased amount of von Willebrand factor, that means qualitative defect. In type 3, there is a deficiency of or full deficiency of von Willebrand factor, that is also a qualitative defect, quantitative defect. And type 2, that is a quantitative defect, that means qualitative defect. The von Willebrand factor is there, but it cannot doing this normal work. So this is the von Willebrand factor deficiency disorders, and the patient may present with purplic spot as because there is a platelet is not getting adhered, and there is a decreased amount of primary platelet and primary clot formation, and there is a so patient present with purpura or patechi or easy bruise formation of easy bruise after trauma, or there is a presence of on and off bruise in some part of the body which is unlikely to have some this type of bruise, and there is a they may present with the child, mainly the girls may present with a huge amount of bleeding during the periods because of the and this is called menorrhagia, may present with a von Willebrand disease. So patient may present with may remain asymptomatic as if there is a decreased amount of von Willebrand factor, but if there is a full deficiency, the patient may present with on and off purpura or patechi in the body, and also there is a chance of bleeding after the trauma or presence of bruise or abrasion in any part of the body after trauma. And factor 8 deficiency, it is an X-linked deficiency, X-linked disorders. That means X-linked recessive disorder is mainly present with a male patient, and there is a family history of a male patient having some problem of bleeding disorder. In factor 9 deficiency, that is hemophilia B, this is also X-linked recessive disorder. And factor 13 deficiency, the factor 13 deficiency may remain silent. Many times the patient may present with easy bruisability or easy bleeding following trauma. The patient may present with first one is delayed umbilical cord separation. It is very much important. If any patient having some bleeding problem or easy bruisability or easy bruise after following trauma, and there is a previous history of any delayed cord fall, so think about factor 13 deficiency. This factor 13 is very much important to make a mature fibrin clot. So, and factor 5 deficiency, the factor 5 deficiency and factor 11 deficiency, it is very much important because this may patient present with some bleeding or easy bruisability after following trauma. The liver dysfunction, as the liver produces factor 2, factor 7, factor 9 and factor 10. So if the deficiency of these 2, 7, 9, 10, that means a problem in the intrinsic pathway and also the common pathway. So this may be a problem after the liver dysfunction. The factors are not produced and there may be a chance of bleeding. DIC means there is a consumption coagulopathy, that means the increased amount of consumption of platelet, and also there is a increased amount of consumption of coagulation factor also. And after that there is a decreased amount of coagulation factor which causing increased amount of bleeding. Factor K deficiency, in factor K deficiency there may be a presence of factor K is very much important for the for the absorption of this factor 2, 7, 9, 10. So if there is a factor K deficiency, the factors which is produced from the liver is not getting carboxylated, and there is a problem of this coagulation factor. So factor K deficiency due to problem in the small gut, or also if the patient taking prolonged antibiotic therapy, there may be a decreased amount of factor K, and this causing bleeding problems. So these are the problems in which the patient present with bleeding problems. So in coagulation factor, the patient may present with easy bruisability following trauma, or the patient may present with spontaneous bleeding, and that is huge amount of bleeding in the knee muscle after trauma. That means may patient will present with hematose or some other intracranial bleeding following fall. And in platelet problem, there may be a patient may mostly present with some problem, that means Patchy purpuric spot. It is most common. After that, huge amount of bleeding. Bleeding is there in platelet problems, but it is very rare. But in coagulopathy, purpuric spot or Patchy, it is very much rare. But huge amount of bleeding problem may be there. So this is very much important to differentiate between platelet disorders and also the coagulation factor in a bleeding patient. So if a patient present with a small amount of pathogen, so what is the definition of pathogen? If the diameter of a small red papules, if it is less than 2 millimeter, it is called pathogen. If the diameter is more than 2 millimeter, it is purpura. If it is more than 1 centimeter, it is ecchymosis. If there is a the bleeding is elevated the surface, that is called bruise. So these are the different definition of patchy, purpura, ecchymosis, and bruise. So this is hemarthros. It is mainly present in patient of following trauma. That means a patient with coagulation problems, and easy bruisability or platelet problem. A patient present with platelet disorders. So after, if we found a patient having bleeding problem, that means if we present with a small purpuric spots or some bleeding problem, then we have to do some primary basic investigation. After that, we go to specific test or some higher test. So the primary investigation is very much important. So we have to see the CBC. If CBC, it is most important, because if the platelet is the patient present with a purpuric spot, platelet or pathogy or ecchymosis, if there is a platelet count is low, think about ITP. If the patient is well, it is playful active and if not sick looking. If the CBC report shows decreased WBC or decreased all the three counts, so in CBC, if the WBC count is low, hemoglobin count is low, and also the platelet count is low, then think about some aplastic problems. If the patient having some high amount of platelet with decreased amount of hemoglobin and platelet high amount of WBC count, so the patient may present with sepsis. If the patient may present with decreased amount of hemoglobin with normal WBC count and with decreased platelet, then think about Evans syndrome. If my patient present with normal hemoglobin with a decreased amount of platelet and there is a presence of small amount of allergy all over the body, that means dermatitis, and then think about Wiskott-Aldrich syndrome. If the patient may present with a decreased amount of platelet with decreased amount of hemoglobin and normal WBC count, and also my patient and having some features of fever, then think about dengue. So CBC is very much important. Liver function test is very much important if the patient having some LFT problem, that means liver function problem. So there is a problem. We are finding that patient may having some bleeding problems. PT epidity INR is very much important because PT is mainly seeing the extrinsic pathway. So PT is seeing the extrinsic pathway and epidity is defining the intrinsic pathway. So intrinsic pathway, that means the factor. What are the intrinsic pathway? What are the intrinsic factor having extrinsic pathway? Extrinsic pathway is having factor 7, and intrinsic pathway is factor 9, factor 11, factor 12, factor and factor 8. So these are the intrinsic pathway, and also both the common pathway is seen by the PT and also the APTT. So PT and APTT both seeing the common pathway, and also PT seeing the extensive pathway, and intrinsic pathway seen by the APTT. So if there is a only the PT is increased and INR and APTT is normal, that means the intrinsic pathway problem. That means tissue factor problem, or that means the problem in the factor 7. It is factor 7. And if the APTT is increased but the PT is normal, then think about some problem in the factor 9, 10, 12 or factor 8. And if the PT is increased and ability also increased, then think about some common pathway problems. What are the common pathway? Factor 5, factor 10, factor 5, factor 10, factor 13, factor 2, and also the calcium. So these are the problems in this. So PT and ability is very much important to define the common pathway and also the extensive pathway. Now the specific test. Specific test is very much important. If we found that the patient having some signs of sepsis, then we have to do the fibrinogen test, as because if the in fibrinogen test and D-dimer test, it is decreased in DIC. So and also the sepsis. ANA profile you have to do if the patient having some pulmonary spot along with the malar rash. We think about SLE. So SLE is very much important to rule out if the patient having some idiopathic thrombocytopenia. Torch pan is very much important if there is a newborn having decreased amount having some pulmonary spot all over the bodies, and also the newborn present with decreased amount of platelets. So always do the torch panel, because in congenital torch infection there is a decreased amount of CMV infection, there is a decreased amount of platelet and which may be present with bleeding problems. Now, this is the approach. So, if a patient present with patchy purpuric or bleeding spot, the first primary investigation, as I say, we have to do CBC, PT, PDT, INR, and also fibrinogen level and peripheral blood smear (PBS) study. So, after that, we may consider von Willebrand factor testing if the history supporting von Willebrand factor deficiency disorders, like if the patient having recurrent type of, normally patient is normal, but if the patient may present with small bruise or recurrent on and off patchy purpuric spot all over the bodies, or bruise are following trauma, or there is a family history of bleeding problems like this, or there is a family or there is a girl present with excessive bleeding during menstrual period and also having some easy bruisability or purpuric spot all over the body, then considered von Willebrand factor deficiency. So after that, after the report, if the PT is increased, so if the isolated PT, if the PT is only increased, the ability is normal, that means the factor intrinsic problem in the extensive factor, that means problem in the factor 7. So we have to do the factor 7 assessment. If the ability is only increased but the PT is normal, that means the intensive problem in the intensive pathway, that means factor 8 deficiency, factor 9 deficiency, factor 11 deficiency, and also factor 12 deficiency. So these are the problem, that means hemophilia. So we have to do then the factor assay, and if the PT and ability both are increased, that means there may be a problem in the common pathway. So common pathway, there may be a problem in either due to the DIC or some problem in common pathway problem factor deficiency. So if the fact, then we have to do the factor assessment. If all the factor are decreased, that means all the factor 5, factor 7, factor 8, factor 10, 12, it is decreased, then it is DIC. If only the factor 5 is decreased, then it may be a problem in the liver, because in liver there is a, as I say, in liver disorder the factor 2, 7, 9 and 10. So in liver problem, or in the, if the vitamin K deficiency, the common pathway which is present factor 10. So if the factor 10 is deficiency, or factor 9 in intensive pathway, factor 7 in extensive pathway, factor 2 is common pathway. So if the factor 10 is decreased, then think about liver problems. Now, if the fibrinogen level is low and also PT-PT and INR is deranged, then think about DIC or liver problem. If PT, PT and INR is normal, platelet also decrease or normal, and there is a bleeding, then think about some problem in the von Willebrand factors, or there may be a problem in the platelet function. So if all the parameters is normal but patient having some problem in bleeding problem or history suggestive of some bleeding disorder, think about von Willebrand factor deficiency. So we have to do the von Willebrand factor quantitative and quantitative assessment. How we have to do, what are the tests we have to do for von Willebrand factor activity and qualitative and quantitative deficiency, I will discuss next. So if only the platelet count is decreased and all the PT, PT, INR is normal, and other things is normal, then we divided if the platelet count is only decreased, then we divided it into a well patient or ill patient. If the patient is well, then we divided this decreased amount of platelet problem into two parts. That means either due to consumption defect or due to the problem in the synthesis. So decreased amount of synthesis is due to, as we say, TAR syndrome, Wiskott-Aldrich, or Fanconi's anemia. The patient is well and also there is a TAR syndrome. That means thrombocytopenia absent radius. Wiskott-Aldrich, there is as I said, there is a increased amount of dermatitis and also increased chance of infection along with thrombocytopenia, or Fanconi's anemia due to the bone marrow failure, or decrease and increased consumption due to ITP, as because there is an antibody or HIV or SLE or drug induced, or if the child is well along with maternal ITP or maternal thrombocytopenia, then think about NAIT. If the patient is ill, always think about some infection or some other malignancies. So if the patient is ill, it is divided into consumption. If the consumption problem, that means the blood, the platelet is consumed by the body, that think about DIC or HUS or some infections. If there is a ill patient, and think about some sequestration problem, that means hypersplenism due to malignancy or other problem, or synthesis defect due to malignancy or storage disorder if the patient is ill. So this is the approach in which we can go in a patient of bleeding disorder. Now the specific problem, specific investigation due in specific disorders. So if we suspect the patient having some problem factor 8 or factor 9 due to hemophilia, then we do the factor 8 and factor 9 activity assessment. So it is very much important. Activity assessment, not the amount assessment. It is the activity assessment. So if the activity is decreased, that means factor 8 activity is decreased, factor 9 activity is decreased. If the factor 8 activity is decreased, then it is hemophilia A. If factor 9 activity is decreased, it is hemophilia B. Now the von Willebrand factor, as I say, it is divided into three. One is type 1, there is a small amount of deficiency of von Willebrand factor. Factor 2, there is a qualitative defect of von Willebrand factor. The factor amount is normal, but it is not effectively work. And factor 3, it is, that means complete deficiency. So von Willebrand factor antigen testing, von Willebrand factor antigen testing, this is the qualitative test. That means this is the quantitative test. So if the von Willebrand factor antigen is decreased, then either due to, if there is a deficiency, then it is von Willebrand factor type 3. If it is decreased, then it is type 1. And von Willebrand factor activity, that means richthostatin activity test. If the activity is decreased, then it is factor 2. Then Glenn thrombocythemia, Barnard-Soley, that means the problem in the factor GP1B2A or 2B, 3A, and these are the factors which is present just on the surface of the platelet. So we have to see the surface glycoprotein in platelet wall, platelet. So we have to do the flow cytometry of the platelet glycoprotein. So we have to do the flow cytometry of a platelet glycoprotein. In vitamin K deficiency, there is a PIFCA test. In PIFCA test, we see the vitamin K deficiency, and it is better to do serum vitamin K1 level. If it is K1 level is decreased, then there is a vitamin K deficiency. So these are the tests which is done in bleeding problems. Thank you.